Hello everyone, this is a recording of the presentation around GP CPCS. It's going to cover aspects for general practice side of things and for community pharmacy. There will be a chance for you to ask questions at the end. So what is GP CPCS? Well, it follows on from the successful launch in October 2019 of the Community Pharmacy Consultation Service, which established referrals from NHS 111 for both minor illness and for urgent repeat medication. There were loads of pilots around the country to see how this might happen from other settings, including general practice. And I think the important thing to note, it's from general practice and it's not intended that it should have to be the GP who does the referral. There was a soft launch from 2020 in November to incorporate GP referral into CPCS across the country. And now there's a lot of impetus behind it, and several areas are looking to go live in the next few weeks. This just shows you a dashboard as a point in time to look at the sort of minor illnesses that are referred through the CPCS service from 111, because the GP referral into CPCS is only for minor illness. It's not for repeat medication for obvious reasons. This just shows you that around 50% only require advice, and then there are different sections where they require the sale of a medicine alongside advice, and certain ones where the escalation is required, which is around about 10% once the service is established. During this sort of early implementation, that can be a little bit higher as people get used to what to send. And the categories that most people see, as you can see, it comes under other. That's a bit frustrating, obviously, because it makes it more difficult to see what the real use of the service is. However, there's quite a lot around skin, cough and cold, and hay fever and headaches, depending on the time of year. This is just an illustration of the process map for the referral process. It's starting with when the patient contacts the GP practice, and this is through whatever mechanism you're currently using, because obviously things have changed a bit. It may be face-to-face, more likely to be phone, or through some sort of online triage system. And then the next stage is when someone is identified as being suitable for the community pharmacy minor illness referral process, then using whatever system the surgery currently has in place, this then sends a message through to community pharmacy, either through a standalone NHS mail system or an embedded system which sends it automatically to an NHS mail, or a fully integrated system. Then in the pharmacy, they have a face-to-face, phone or virtual consultation, or a combination thereof. And then there are various outcomes that are possible, all of which are recorded on a post-event message which comes through to the surgery through Pharm Outcomes. Obviously, if an escalation is required, then it's not, although the information will go through Pharm Outcomes, the actual referral and feedback will be by phone to the surgery in order to sort out an escalation point if red flags are established. This just shows you some pictures that are from a presentation that's available for practice teams to explain a little bit about the service. So this is just a screenshot of some of the slides. It goes through the whole service, but it also has some practical tips for the reception team who are fielding the calls and how to put things across, and some frequently asked questions and possible answers, etc., to try and help them navigate that part of the conversation, because that's obviously critical to get the patients on board. And this will be easier if you've had some form of care navigation previously. This is the list of the suggested minor illnesses that would be suitable. And on the left-hand side, you can see the main conditions, and then there's some sort of subsections within it on the green section. And then on the right, there's some red flags. Now, this can either be part of the conversation with the patient at the reception end, but it will be picked up by the pharmacy teams as part of their structured consultation with the patient. If some of these red flag questions are covered off at the surgery end, obviously it reduces the amount of patients who are likely to have to be returned back to the surgery. And that's one of the things that you find that during the testing, you learn how to get that working properly. This is the EMIS template. Now, obviously, this is a word representation of it, but it is actually a template that is in the EMIS system, so that it will actually draw information around the patient directly into the form pre-populated for you. Obviously, the patient's name and that sort of phone number, etc. And then there's an opportunity to link in the list of pharmacies in the PCN so that you can click straight into the box and onto their NHS mail. And then the reception team save this form, and then a copy of the form is emailed through to the pharmacy. And there's an option to either free type the reason for referral, or there's a tick box section as well. You can use either or both. For those that use care navigation, this is just an illustration of how the Herefordshire one was set up even before CPCS started. And as you can see, they had an A to Z list basically of all the things that could be managed through pharmacy. And some of the red flags were put underneath, which just sort of prompted the odd question for the reception team. And then they had already set up a series of options of where they could refer someone to. And one of those is sending them through to community pharmacy. Now what they've done is they've linked into that the EMIS template form, so as they mark that they're going to send them to community pharmacy on the EMIS setup, they actually then use the EMIS template and send that directly to the pharmacy, so that it's only one extra step in their process. Some people use the Ardens template. There's a link here, and the slides will be are available on the LPC websites. And this will give you a link to a YouTube video which explains a little bit more about the Ardens template. But if anyone's interested in that, if you contact the LPC, we've got more details on that. But it's a similar idea to the care navigation piece in that you use it for producing the template, which you then send on to community pharmacy. In all of those cases, it ends up with an NHS mail with some sort of attached form appearing at the community pharmacy end, and then the pharmacy team would have to put it onto Farm Outcomes as they were doing the consultation. Once they get to the consultation point, the outcomes are as set out here. One of the things that's important to understand is it's a structured consultation which they do whilst using Farm Outcomes, so they do have links to check the summary care records and to also look at the NICE clinical knowledge summaries and pick up on any red flags, etc. So any red flags, if that happens, and this is once stabilised, usually around about 10%, and it depends a bit on how much there's been in the way of questioning at the practice end, obviously. This is then managed immediately, and either the patient is directed to 111 A&E or more likely an escalation back to the practice. And this is where it's important to have a local protocol in place in order to understand what is the best mechanism for contacting the practice and what time their cut-off is for getting someone in to be seen the same day if that is necessary. And that's usually around about 4 o'clock-ish in the afternoon. And usually there's a healthcare professional phone line which pharmacists can use just for this service and not for other health queries. Then the pharmacists may, for the majority, and it's usually 40 to 50%, provide advice only and links to self-care and homely remedies, things that they may already have at home. Another proportion will have similar advice but will need to purchase a product. It's important to understand that the patient does have to pay for the product. That's not included in this consultation service. And then some may be referred on to other NHS services, including, for example, the extended care services, which is a range of PGDs in order to support UTIs in women and infected skin, and soon there will be some related to ENT as well. And it may be that they need to be referred on to another healthcare professional, for example, optoms or dentists. There's always, at the end of any of these conversations, the catch-all sort of phrase around, if you're not feeling any better or you are worse within X number of days, which depends on the condition, then you should come back to the pharmacy or contact your GP. That has to be phrased really carefully so that the patients don't misinterpret that I don't feel a lot better this afternoon, so I'll contact the GP anyway. They need to understand that it's normal to feel a little unwell until things have kicked in or a self-limited condition has resolved, and that they don't need to seek advice straight away unless they're feeling a lot worse. This just gives you some more outcomes from Avon, who have been running the GP into CPCS for some time now. And this is some relatively old data going up to October, but it just shows that even during COVID, there were only a couple of months when it dipped in the numbers. And actually the numbers are now exponentially well off the chart on here, and huge numbers of referrals are being dealt with successfully there. And it just gives you an idea with the pie chart here. Again, it's a snapshot in time as to the proportion that's dealt with in pharmacy or escalated back. And the bottom graph just shows you, the bar graph just shows you the age group. So you can see there's actually quite a lot of working age group and children that are managed through this service, which I suppose is not surprising. And as in the Midlands, just to show you the first 800 referrals across the whole Midlands. So that's 11 ICS footprints. And this is just to give you an idea of the sort of conditions. And as you can see, frustratingly, other is the highest. But skin rashes are quite high, sore throats, earache, diarrhea. So you can see the range of things that are being dealt with, which obviously mirrors, as you would expect, the minor illness list. And again, just gives you an idea of across those 800, the brown one is the advice only, and some are signposted, that one there, and some referred to the PGD service, which is growing in interest. And more pharmacies are signing up to those all the time. So I can see that segment being increased. So how does it differ from just asking a patient to visit the pharmacy? I think it closes the loop. Patients are far more likely to go and attend when they know it's a structured interview and a proper appointment with the pharmacist, and actually a large proportion of the things are solved by the pharmacy. And you also get the feedback link into the GP practice so you know what the outcome was. And if any red flags are noted, then the pharmacist will contact the surgery. So it's a safety net as well. There's quite a nice little animation which explains a little bit more about the service, and the link is there. That's very useful for practice teams just to see an overview of what it's all about. So obviously we've been through quite a lot of implementations, and so quite a lot of things have been learnt. So some of the things that are important to note is that 97% of pharmacies are already signed up to provide the community pharmacy consultation service, which means they automatically are signed up to provide the GP referral into the service as well. And the pharmacist must be able to provide the service all the normal opening hours. And so locums need to be aware, and someone always has to be on hand who can access NHS shared mail so that obviously they can get the referrals come through. If there is an emergency where that's not possible for the pharmacy, so some serious problem has occurred, then they are expected to contact both the DOS to tell 111, but also the local surgery to say they're suspending the service just for a period of time, and to inform the surgery how long that will be and let them know when they're back up and running. but generally speaking, it should be available the whole time the pharmacy is open. In practice, what we find is that most of the referrals come through between 9 and 2, but there may be some later on into the afternoon as well. Again, when we collect information both from the surgery side as to around contact details and cut-off times, we also do that for the pharmacies as well, so that we know when their opening hours are, and so that there's an understanding as to anything they receive within the last hour, the patient might well be contacted the next day. And it's perfectly reasonable for support staff to actually contact the patient and arrange a suitable time, or to text the patient, whatever mechanism is agreeable. And then the pharmacist must undertake the consultation in a consultation room so that they're not disturbed, and using the Pharm Outcomes process. Someone in the pharmacy team needs to check the NHS mail regularly, at least first thing, mid-morning, lunchtime, mid-afternoon and before close, just to make sure all of the referrals are picked up. We will make sure that the pharmacies know when the surgeries are going live, so when to start checking their NHS mails more frequently. It's really important that the pharmacy knows the protocol for the surgeries that they deal with most frequently and the mechanism by which they contact the surgery. The only time the pharmacist would just tell a patient to go back to the GP or return to the pharmacy would be after completing the consultation, when the catch-all statement is given. The pharmacist will complete the consultation on the CPCS template on Pharm Outcomes, and a copy will automatically be sent through to the GP record. Some practices have added additional things, so that they might allow a pharmacist to message the repeat ordering system if it's for a prescription for something where it's a licensing issue around sale, but in other surgeries they actually still want to see the patient, so that will be a personal discussion between the pharmacy and the surgery during the testing period. So again, as I say, local protocols are really important, and once that information is really clear, and in particular, for example, what the practice wants to do about a patient who refuses to purchase over-the-counter medication where the pharmacy thinks it's important, how that process might be managed, whether that might be a prescription or a return to the surgery, etc. This is another way of looking at the referral process. It's a proper process map with swim lanes that people might find easy to understand. So the top line is everything to do with the GP end. Then there's a little bit of the admin bit in the middle, then the pharmacy end of things, and just some other notes around possible follow-ups, etc. But in principle, it's as before, it's all about the patient who contacts the surgery. It's not someone being directed to the surgery to make contact. It's a patient who would normally contact the surgery anyway, being navigated through a decision being made that they're suitable to go to community pharmacy, the referral process, whichever is being used in your particular practice. A lot of people are using the embedded form, which will go through to NHS Mail, but there are all sorts of other possibilities as well. And then the pharmacy dealing with it, as we have discussed, and if they need another service, letting following that through as well. And then the information goes through as a post-event message so that practice knows what the outcome was. Obviously, if anything needs to be dealt with urgently, you contact the practice immediately. You don't wait for someone to pick it up in the Pharm Outcomes message. This is just a reiteration really of the local protocol points. There's something around referring into other services here, which includes the extended care PGDs, which I mentioned earlier. And I know in Herefordshire and Worcestershire, for example, if there's an issue around eyes that you can't deal with, that there is a referral process into the optometrist as part of MEX. So we ask for pharmacists and GPs to share information, which we then share by PCN. We've completed the pharmacy part. We're just waiting for the PCNs to complete their part from the surgeries as and when we're starting to go live. This just shows you what that information sheet looks like. It's obviously surgery address, a contact, regularly check secure email, healthcare professional line, their opening lines, their cut-off time for same-day consultations, EMIS or whatever IT system they're using. This is largely EMIS in our area, some system one. And then this is the bit we've already completed, an LPC for all the pharmacies. It has all the details on. The thing we're looking to add, which is the final column, is which pharmacies provide the extended care services, and we're waiting till the end of June once the list stabilises a bit, because it's still a little bit out of date, so that we can share that information, because that, for those that have gone live, that's a big one where people want to refer. So sort of reiterate some of the implementation preparation. Obviously there's on both GP side and community pharmacy side, it's agreeing all the timelines for testing and going live, agreeing the principles around the local protocols, making sure everyone knows the numbers, etc. That the official referral process is confirmed and is in place, along with links to the pharmacies for sending it through, that whoever's receiving the calls from patients or haven't had some training and understand what process they've got to follow and how they send it through, and how to manage the feedback loop for any red flags, and link it in to current processes as much as possible, so that it's not something, yet again, something new for the practice teams. And it's important to do some testing with some buddy pharmacies and then expand to the whole PCN or all the pharmacies. And you can go by one surgery at a time, whichever way suits. But the testing is really important to just make sure everything works and there's an understanding of how to escalate things, etc. From the pharmacy point of view, obviously waiting to see what the protocols are, making sure all the teams fully understand the service. In particular, it's important that the counter staff understand, because when patients phone through or appear, they are not likely to say, I've been referred on the GP CPCS service. They're more likely to say, I've been told to come, or something like that. So they need to be able to just check whether or not they've been in touch with the practice that day, so that then the pharmacy can just check on the system to see if they've had a referral through. Otherwise they can be missed. And we have had a few cases where the patient's been in, didn't really make it clear, the pharmacy didn't necessarily ask any questions to make that, to find out, and they were just dealt with in the normal way, and it didn't go through the whole system at all. So there wasn't any sort of information going back to the surgery, etc. So we want to make sure that that doesn't happen. Also, to make sure that the teams understand the specification that you've claimed for your Annex F, which has to be done by the end of June, and that you've looked at all the information that's available. There's lots of training, including some on farm outcomes. There's some through RFPS and MPA and all sorts of other bodies as well. Links to all of that is on the website. And then make sure that everyone knows that the service is up and running, and start checking the NHS mail regularly and get into that good habit. The extended care service, I'll just mention this briefly. This started in December 2020 with Tier 1, which is the simple UTIs for women up to 64, and it gives the opportunity for pharmacists to go through a process and structured conversation to determine whether or not it is an infection, and if it is an infection, to provide nitrofurantoin. And then the Tier 2 is around infected insect bites, eczema and impetigo, and again similar sort of process, but there's also antibiotic options to support that as well. And coming soon, which we hope will be for the winter, there will be some selected pharmacies that will have additional training on how to look in ears and throats and all the rest of it, so that they can offer an ENT service with antibiotic options as well, which again will increase the number of referrals through to the service, although patients can be self-referred and pharmacists can just offer the service without any referral. This just gives some background documents which might be useful from a practice point of view, which just has some articles around the service. There's also at the bottom the link to the virtual outcomes training for practice teams, and there's a code which they can use, and it's free, and it's about 25 minutes. So that's quite a useful background thing for surgery teams to look at, to see if they can support some extra information for the practice teams. And now we'll come to some questions. Thank you very much.